So good evening all. For today's episode of e-Gurukul, today we have a case presentation and discussion. The system we have chose is nutrition, and we know that nutrition is nowadays not only malnutrition, it is malnutrition also. So we are seeing both the types of nutritional variations. One is severe deficiency, another is severe excessive nutrition. So let's see where our case presentation and discussion takes us. So I welcome our President, Dr. Jhankhana Sanghavi Madam, for her welcome address.
Thank you, Dr. Nehal. Good evening and welcome, Dr. Baldev Prajapati sir, Dr. Sandeep Trivedi sir, our today's mentor, Dr. Gosai sir, today's expert, Dr. Jai Singh, our own secretary, Dr. Nehal and Dr. Lata Jam, and today's batsman, Dr. Priyanka. She is the today's whole and soul, today's batsman. Nutrition is always a debatable one. Always discussion on nutrition is going on. And I know 100% with the help of mentor and expert, our today's batsman, Dr. Priyanka, will do a hat trick. Let's watch her hat trick. Over to Nehal, please.
Thank you so much, madam. So with this wonderful welcome address, I hand over this platform to Lata, who is Chief Project Coordinator for this e-Gurukul Pathshala. Lata, please.
Thank you, ma'am. So good evening, everyone. So again, a new case, a new scenario with nutrition. So presenter for today is Dr. Priyanka Dehury. She is third-year resident at Bhavnagar Medical College, Gujarat. And her mentor is no other than Dr. Mehul Gosai sir, who is professor and HOD there. The expert for today's session is Dr. Jai Singh. He is Principal Specialist Pediatrics at Mother and Child Hospital, Govt Medical College, Chittorgarh, Rajasthan. Sir is Nodal Officer at RNCRG. And he has been National Secretary of IYCF, as well as he is a National Faculty for NRP, NSSK, NRC, and FIMNCI. Welcome, sir, for today's session.
Thank you, ma'am. Thank you.
Ma'am. Nehal, ma'am, should we begin?
Yes, so platform is all yours, Baldev, sir. Take us.
Good evening, friends. Welcome to this our academic session. As I came to know, Dr. Priyanka is the presenter. She is from Bhavnagar Medical College. And Dr. Mehul, all of us know, he is the mentor. I request that other students to point out so that we can make them to participate in the discussion. Dr. Priyanka, can you help me? Who are other your colleagues from Bhavnagar Medical College who have joined over here? Priyanka, I think you are using two modalities, so you can switch off one. And suppose if you are sitting together, then I think better to make on and off one by one.
Priyanka, mobile and both are functioning. Just एक laptop चलाओ अपना आप, है ना? Laptop पे रखो. दो पे मत open करो. It will be difficult for you.
Sir, homework.
Unmute yourself. Now it's okay.
Thanks for joining, sir.
Yeah. Priyanka, is there anybody from your college who is present on the screen? Any your friend, colleague?
They are joining soon. As far as till now, yes, few of my juniors have connected.
You can share the screen, Priyanka.
Yeah.
Is there anyone for technical help in the room?
Mehul, I think you can identify some other students from your college. And I'm sure that once your voice is there, it will make the difference.
Yes, sir. I have instructed.
Who are they? Can
totally
you identify? Is there anybody on the screen at present?
Yes. Ek minute, sir. Yeah.
You can check the screen and you can. Okay, I think we can start, and meanwhile they will join, and we can
yes,
take
sir, We are joining, sir.
Okay,
But
okay.
we can start, sir.
Yes, yes. So, Priyanka, you can share your PPT and start the history part.
Yes, sir. So my screen has been shared.
Priyanka, make
Yeah.
it full screen. Full screen, full screen. F5.
Already on full screen mode, ma'am.
No, it's not. It's not. You start slide sharing, huh?
I think,
Start share.
or otherwise,
Full screen.
yes, that is the full screen. Yes, your
F5,
cursor is
you
at
press
point.
F5.
You can click it.
ये कीबोर्ड पर F5 प्रेस करो तो ये हो जाएगा, स्लाइड शेयर स्टार्ट हो जाएगा.
I think Dr. Nehal is there with Dr. Priyanka. You can guide her regarding the full screen.
But we have already done full screen. In our computer, it is in full screen mode. But if you are in other computer, they are in
Then Nehal, I think you can again do it so that it will be in order.
1 minute, sir.
You can stop sharing and then again start to share so that it will be sorted out.
Okay, sure. Okay. Windows. Sure.
हाँ, सुनो प्रियंका, listen.
Yes,
तेरे
sir. Yes, ma'am.
स्लाइड शो दिख रहा है? स्लाइड शो में क्लिक करो, फ्रॉम बिगिनिंग करो, तो फुल स्क्रीन आके अपने आप स्लाइड शो स्टार्ट हो जाएगा. Okay, do that thing. You got my point?
Yes, ma'am.
Anyway, you can take your own time. We are not in a hurry.
Screen share channel.
You can take the help of a standby laptop if it is not possible from the big screen of the seminar room.
Share करिए. Now it is on share mode. But
हाँ,
in
it's
full
okay.
screen mode,
अभी तुम स्लाइड शो स्टार्ट करो ना, स्लाइड शो फ्रॉम बिगिनिंग, वहां से स्टार्ट नहीं हो कर पा रहे हो. स्लाइड शो क्लिक करो, हाँ, फ्रॉम बिगिनिंग करो.
computer it is already on it.
मैडम कॉर्नर से करो, आप हो जाए.
कॉर्नर लेफ्ट में फ्रॉम बिगिनिंग लिखा है ना,
वॉल्यूम है, वहीं से करो आप. माइनस के बाजू वाला
નીચે
करो.
રાઈટ લોઅર મોસ્ટ એન્ડ માં સ્લાઇડ શો છે, ત્યાં ફૂલ સ્ક્રીન છે, એના ઉપર ક્લિક કરો તો થઈ જશે.
હા, બસ
એ
એની
ના
પર
થાય,
કરો.
એની પર કરો.
અને એ ના થાય તો immediately change the source, log in from the laptop, so that will be very easy.
Full screen mode. In our computer, it is in full screen mode. In viewer access, they are in different mode.
So, Hinal, you can change the device. That is one.
મેં કીધું ને,
I am logging.
લેપટોપ ઉપર આવી જાઓ. I think Zoom ને AOP હારે કંઈક ડખા લાગે છે, ખાલી લો છો. We need to, સંદીપભાઈ, એકાદો વર્કશોપ જો બાકી હોય તો રાખી દો વેસ્ટર્ન પેડિકોનમાં. ટેકનિકલ ગ્લિચીસ એન્ડ ઓપરેશન એન્ડ સોલ્યુશન ઓફ ઓનલાઈન મીટિંગ.
ફરી વખત કરને.
સર આપ અનમ્યુટ કરીને બોલો. સર સંદીપ સર,
વર્કશોપ ની ક્યાં જરૂર છે? ઝૂમ પર જ બીજી એક મીટિંગ કરી લઈએ ને કાલે. એમ હાઉ ટુ ડુ
અંદર ધ ટેકનિકલ ગ્લિચીસ. બરાબર, રાઈટ સર.
હવે થઈ જશે. નીચેથી કોર્નર પરથી થશે.
મને એવું બી લાગે છે, respected all the dignitaries and Dr. Jhankhana ma'am, Baldev sir, Dr. Lata madam and all, કે this is learning for us also, કે before logging to the Zoom, at least I have also not checked. As a mentor, I should check, mock run this presentation by creating some small meeting. એટલે આવા નાના મોટા ટેકનિકલ ગ્લિચીસ માં ટાઈમ ના બગડે. એવરી મેન્ટર નેક્સ્ટ ટાઈમ
ઈચ એન્ડ એવરી ટાઈમ 5-10 મિનિટ પહેલા ચેક કરી જ લઈએ છીએ મેહુલભાઈ રૂટીનમાં.
અમારે એન્ડથી સર એઝ એ મેન્ટર માનો કે મેં જોયું ને આજે, તો મેં આખું પ્રેઝન્ટેશન જોયું હતું, પણ ટેકનિકલી મને એટલે એવું લાગ્યું કે ભાઈ ઝૂમમાં કોઈ ઇશ્યુ નહીં થાય જે રીતે અત્યારે આપણે ફેસ કરી રહ્યા છીએ. તો વી શુડ ધેટ ઓલસો ચેક.
नहीं है सर, शेयर तो कर देते हैं
Anyone
पूरी।
can make a GMC pediatric host. We will share from that computer.
મેહુલભાઈ તમારી જોડે જો સ્લાઇડ હોય તો તમે લઈ લો, રન કર દો.
हाँ हाँ सर को होस्ट बना देते हैं।
नहीं नहीं, वो हमारा जीएमसीबी को बना दो। मैं एक्चुअली कार में हूँ, so otherwise definitely I would have taken.
Anyway, I think if it is not possible, even this will do.
With this,
Yes.
I think so.
co-host
already
You can
33
do it
people
from
has
there
joined.
also.
The better we will start with this.
મેં GMCB ને પણ co-host બનાવી દીધું છે, if you want to co-host.
હિનલબેન જો તો હવે થાય છે, તમને કોસ્ટ એસાઇન કરે છે.
No, same.
Shared. Sharing બંધ થઈ ગયું.
એમાંથી વ્યૂ ઓપ્શન માં તમે જો અહીંયા આવે છે પાછું ચલો.
Yes.
now it's okay.
Now, yes.
Now it's okay.
It's a full screen. You can.
Yes.
Next કરવો કરજે ને, અહીંયા શરૂઆત ને યાર, આ તો શરૂઆત. Go in this.
It is okay.
Present.
Start.
Yes, Priyanka, you can start.
Yes, Priyanka, you can start.
Fine.
Keep this and start. If you want a next slide, then just say me. I will not do that.
So, good afternoon, everyone. This is Dr. Priyanka Dehury, resident. I'm going to present a case on malnutrition. And my patient name is Ruvin Mahesh Bhai Makwana, who is a 11-month-old male child belonging to Chittorgarh village of district Bhavnagar. Informant is mother, who is a reliable source of information, uneducated in education and housewife. And date of admission, patient was brought to the OPD, pediatric OPD of Surti Hospital on the day of 21st of June. And I examined the patient on 3rd of July, and patient was discharged on 7th of July. Total duration of stay, 3 days in ward and 14 days in NRC. Marriage is non-consanguineous marriage, and socioeconomic status, lower socioeconomic status as per modified Kupuswamy classification 2026. Chief complaints. Patient mother complained of not gaining weight as compared to peers since few months, and complained of swelling of bilateral foot since 15 days. History of presenting complaints. Child was apparently normal 6 months back, after which mother noticed that the child was not gaining weight as compared to his peers in the last 6 months, and mother gives a history of bilateral swelling of both feet till ankle since 15 days, which was insidious in onset, gradually progressed, and limited till bilateral ankle, fitting type of edema. There is no diurnal variation, and the swelling does not increase. The swelling does not increase height. and not involved with abdominal distension, does not involved with facial puffiness, and no any history of abdominal distension.
I think, yes, Priyanka, can you stop sharing? And I think you have prepared in a PPT mode or some PDF or something. Anyway, whatever, no problem. Can you stop sharing for a while?
Yes, sir.
In the presentation, what we will do, that after some information we'll analyze, I will request to stop sharing, then we'll discuss and then we'll take it further. So at present, please stop sharing.
Okay.
Okay, fine. In the exam also, particularly probably I will discuss the way exam commonly people are taking so that you can have the idea. Another thing in the exam, never make the statement that I am present in this particular case. Not necessarily what you understood may be the right for me. Right. So better to call that this particular child, 11 months old male child, I am present in this case. Don't make this some condition like malnutrition or it is something CVS or cerebral palsy. So better to remain away from making this type of statement. Second, never address to anybody as uneducated.
Yeah.
Mother might have not gone to school or something, not necessarily she is uneducated. Many times we realize that in spite of her education, she is far away, far ahead. So, these are the small points, but some examiners may not like it. And I think as a whole, even when we are presenting or talking in some, I would say, general forum, we have to take in mind that what things people may accept us. Even one more point that, mother is always reliable. When we say that informant is mother, better not to make again this statement that she is reliable. Mother is always reliable. As a clinician, I may not be reliable, but she is. So again, these are the small points, but yes, some examiners may take the note of it. Somebody will ignore during the exam time. Somebody will make it the issue. And then your time will be probably taken for that discussion. So keep in mind that when we are talking, my selection of each word is in such a way that hardly the examiner is getting the space. And for that reason, once you go for multiple times presentation, then probably as we do multiple times, yes, that will be the good improvement. One more point, even small again point, once you say swelling bilateral, it is feet, it's not foot. When we say bilateral, that means it is plural, it is not singular. Maybe I will say grammatical or English mistake or spelling mistake. That's why again I will say that during the presentation, you should be physically 100% present and mentally alert and even choose every word. I think in our discussion also I will guide you that choosing the appropriate word in medical terminology also conveying the exact meaning. And it makes difference. This is not only for Priyanka, because she is presenting, I am addressing to her, but probably all the students. Even as a whole for all of us, it makes difference. Anyway, but it's very important. Now coming to our case, she said that here the 11 months male, she had made the two complaints. One is not gaining the weight and swelling over the feet. Again, Priyanka, you said in your description that it is pitting type edema. Complaints will be in the language of the parents or mother, whoever the informant. She will not be able to say pitting, non-pitting. It's just she will say swelling over both the feet. So that we'll have to mention. Of course, in examination, then you can see and check and everything and even describe or narrate in your own language. But when we are putting in the history, that should be exact in the words of the parents or the informant. Right? So here, I think during that time, we can say just swelling or even edema, okay, that you can utilize the terminology. Now, let me start with other students. Dr. Priyanka has made the statement, not gaining the weight, and child is 11 months old. Priyanka, anybody is there from your institution? Or I can identify some other students. I think they should come out that I am from this particular institution. Priyanka, is there anybody?
Yes, sir. My colleague is there, Nikunj.
Sorry?
My colleague is there, Nikunj.
Nikunj. Okay. I think if you are able to keep your video on, it's good. My question is, suppose if you are sitting in the OPD in your outdoor department and the child is brought to you, just with one complaint, my 11 months old child, my child is not gaining the weight. What things will come to your mind? What other questions will ask so that you can have more information? You will gather the information and try to think that what can be the problem with the child. Who will take it? Please, I think when you are talking, it is audible to others also. So please take care. Anybody who will take this initiation? I think, who are the other students? Because here, I don't know exactly, and then I can, yes, Nicole is there. Nicole, can you take it? Yes, Dr. Nicole?
Yes, sir.
Can you take it? As I said, you are sitting in the OPD, the child is brought to you with this complaint that not gaining the weight. What other questions should ask the mother to gather the information? Then what will be your thought process that what can be the various reasons when this complaint child is brought in our OPD? Can you give some idea?
Yes, sir. I will ask about any complaint of cough, recurrent infection.
Okay, what is your idea? Another thing, whatever we ask, try to put the explanation that with this information, it will help me for this particular purpose. Suppose if there is history of repeated respiratory infection in some patient may present and not gaining weight, then what will be your thought process? What will be your idea?
Maybe due to repeated infection, patient will be in failure to thrive.
Okay, good. Anything else further?
History of TB contact or any congenital, maternal infection.
Okay. Anything else? Anybody can take it further? Dr. Teja, can you take it? Not gaining the weight, 11 months old child has presented to us. Anybody?
Then I will ask food history.
Okay.
When the complementary feeding started, any complaint of diarrhea or GI tract complaint?
Very good. So dietary history can go in the details. Anything else?
History of pica also, so we can ask if there is.
In what way the pica will be responsible for not gaining weight?
Sir, immunodeficiency and sir, tuberculosis type. Sir.
Okay, Dr. Vinith is talking. Good. For tuberculosis, what information we'll try to gather? Already he said history of contact. Okay, it's a good point. Anything else? No, I think I will give the idea. Once you are knowing that the baby was preterm baby, NICU admission, birth weight was 1.5 or 1 point something, or the baby was low birth weight, is it possible that that baby may not be having the same weight gain what the mother is expecting?
Yes, it could be.
So exactly what we should start the story, that when do you feel, at what age you felt that your child is not gaining the weight? Sometimes they may give the, suppose, as you said, feeding problem, then mother will say exclusive breastfeed, suppose by chance. Baby was fine up to the age of 6 months, gaining the weight. There was no problem. But mother will say after 7, 8 months, somehow not gaining the weight, and at 11 months, it is clear that not gaining the weight. Then we realize that if the child was gaining the weight, good weight gaining in the first 6 months, only on the breastfeeding, then what, Nicole, already you discussed probably the congenital causes and everything is almost out. Suppose babies and malnutrition, or invulnerable metabolism, problem of immunity, some congenital heart disease, or even some respiratory repeated infections, somebody put tear fistula or something, then probably these babies are not going to gain the weight even in the first 6 months also. Therefore, you should ask what are the maturity, what was the full term or preterm baby, what are the birth weight, so that we can have the idea whether was it the low birth weight or not. Then the breastfeeding, exclusive breastfeed or something. Later, at what age exactly mother is feeling that her child is now not gaining the weight. And then rest of the history, yes, for any deciding any cause, right? But what other things will come to mind? Suppose nothing is like this. Birth weight was 3 kg. Breastfed baby. No any repeated respiratory infection, no tuberculosis, nothing is there. But still not gaining the weight. Let me sum what are the other silent conditions. And that you should be able to understand how to differentiate this failure to thrive. Failure to thrive is a condition. Usually we keep restricted to this toddler age. 3 years. In our Indian setup, they are extended up to the age of 5 years. That may not be the obvious reason. And then in that case, we'll have to go into details for workup. So can you, because for undergraduate it's a different story, but for the postgraduate, they're expecting more. That which conditions, without any these type of the complaints of respiratory infections or heart disease or anything, nothing is there. Birth weight was also good, 2.8 or 3 kg. Still not gaining the weight. Which conditions can present in this way?
If complementary diets have not been started after
Okay,
6
that
years.
already we discussed the nutritional
months,
problem. Okay, beyond that, Dr. Mahesh said malabsorption. Which condition is the malabsorption?
Celiac disease.
Which
Celiac
condition with the malabsorption will present? By putting the, I will say any chapter number, that endocrine is not the answer. And that's why I said in the exam, you should be very precise. Celiac disease. What is the presentation of celiac disease? Once you introduce this weight, and then immediately it will not start with the weight, not getting the weight. It will take some time. So probably celiac, this is not the common age for presentation. Which endocrinal, somebody has put the endocrinal, which endocrinal condition can present with not gaining the weight? most of the endocrine conditions, they are having the excess of weight.
Hyperthyroidism.
Suppose hypothyroidism, Cushing, they are on the contrary excessive weight. Any renal condition coming to your mind? Okay, somebody has put congenital hyperplasia. Yes, it can present. Congenital hyperplasia can present with not gaining weight, maybe even some other complaints also. Yes, somebody has put very good renal tubular acidosis. Many times they may present just not gaining the weight. What was my idea to ask these questions? And in the examiner is not interested in one particular condition which you have prepared. Examiner wants to know that what is your depth of knowledge in the field of pediatrics. And therefore, he will ask different aspects. That suppose 11 months old child has presented to you, what other questions will ask, starting from the antenatal any problem, birth history, what are the maturity, what was the birth weight, what the feeding was started, and in the feeding also whether exclusive-based feeding, complementary feeding was started appropriately or not. In spite of all these problems, then you will go for other associated complaints, repeated respiratory infections or something which may be respiratory cause or cardiac cause, or even some silent like endocrinal, congenital hyperplasia or renal tubular acidosis. Like that, in short, they want to, yes, even GID can also be there. So that's another thing. Now, one more question. Suppose if you forget is regarding the first complaint and second complaint, now if you focus that the swelling over by both the feet, it is bilateral. And suppose you decided that there is a swelling, yes. Which conditions will come to your mind? Presenting with bilateral pedal edema, what I mean to say.
So there could be cardiac causes, renal causes. Then we can, in case of...
Priyanka, I'm not so fast to understand. Right? And in the exam also will have to make out because already you have prepared. But suppose 11 months old child and cardiac condition is there, do you expect that it will present with the bilateral pedal edema? 11 months old child, even in spite of the cardiac failure? In other way, if I ask you, what type of edema develops in a case of congestive cardiac failure? Dependent part, right? In 11 months old child, it is not going to be the dependent. Some older child, walking child, yes, that child may present with the pedal edema. But 11 months old child, even in spite of this, I would say cardiac cause and cardiac failure, the edema, if at all if it develops, it will not be the pedal edema. It will be the base, maybe the generalized edema, maybe the excessive weight gain, like that complaint may be there. Or even suppose the child is remaining due to some condition, the lying down posture for longer time, edema will be at the back in the sacral region, right? But suppose bilateral pedal edema.
Any case of synthetic dysfunction due to chronic liver disease.
Okay.
And mostly in nephritic syndrome, but the edema will start from the face and then progress to pedal edema. So mostly the facial puffiness will be prominent in case of nephrotic syndrome.
Right. Please always in any case of edema also, what questions you should ask, how to gather the information. It's very important. Don't jump for the diagnosis. And nobody can jump for the diagnosis. If it is so obvious, we will not go for the discussion. Right? That means we are trying to understand. In a case of edema, we will see there where it is, from where it started. It's a very good point. Before that even, is it the localized or generalized? Localized edema can be due to the several reasons. In a case of, I will say, suppose insect bite, or even some tourniquet application, or deep vein thrombosis in a case of nephrotic syndrome, there will be a local edema. If it is generalized edema, then again you will go how it started. Suppose if it started from the face suddenly, it may be the angiotheretic edema. Right? Suddenly it will start. But suppose renal, even I will say renal edema will start from the face. Right? Cardiac edema, as you said, dependent part. Liver usually present with the ascites. Then progress takes place and all over the body it will spread. But how it started? But suppose if somebody is asking this question that what is the most common cause for bilateral pedal pitting edema in 6 months to 5 years old child? You know, these type of the OSCE or very specific question they can ask you. Answer will be only one. Bilateral pedal edema, age is 6 months to 5 years, and pitting edema. Somebody has put it, yes, PM, but it should say severe acute malnutrition. If you see the criteria for severe acute malnutrition, weight for height, right? And then even the height, weight for height also. On third criteria, even mid upper arm circumference, and even bilateral pitting pedal edema. So I think here on the contrary, you can make the bold statement that 11 months old child has presented with bilateral pedal edema. The first possibility to me is the malnutrition. And here again, now if you link even the first complaint that not gaining the weight, then not gaining the weight and edema together in 11 months old child, most likely my possibility is of malnutrition. You know, you can have the very good clear background to make the statement, which people will accept. Age of the child, how it started, what are the complaints. If you put together, then that will create some picture in your mind that what are the possibilities there. So what is my idea of discussion? You know, it's a clinical medicine that as a clinician, how we should derive this, data collection, what we say, information. That information you should go for the analysis. And from the analysis, create the hypothesis that what is the possibility. And I think if you go with these ideas or exercise, even you can catch the uncommon condition also. But suppose that it's a female child and even the non-pitting edema is there. Even the child, mother is complaining, my child is short also. It's a female child.
Hypothyroidism.
Short stature.
Eczema.
Listen to me, everyone.
Turner syndrome.
Yeah. That's why I put here all the points. Female child, short stature, non-pitting edema. Right. On the contrary, said a knee child should always be confirmed for the Turner in this type of situation. So that's the thing that how it should come to our mind. Anyway, I think before we go further, let us take a word from Dr. Jai Singh. Dr. Jai Singh, you can, I will say, what are the points about left out, you can please take it.
Yes, sir. The best thing is to start with the history, the how did it started. You have very well taken it that how the edema started, whether it was started in the dependent part or it was generalized or it started with some illness. We have to look into that part also. And the feeding history in this part is very important because feeding history, we will get a clue that the child is going towards malnutrition or some other etiology might be there. So we have to take care of the feeding history as well as the sequence of events, how they took over there. Thank you, sir.
Right. Priyanka, I think now again you can share your PPT. Hope we'll not find a difficulty and take the story further. Good. Fine. Yes, now it is full screen. Take it further.
So now we move to the negative history. So there was no history of any greasy or bulky stools, no history of regurgitation of feet, no history of fever, rash, or any joint pain, no history of crying while passing urine, red colored urine or frothy urine, facial puffiness, dribbling of urine, or cola colored urine. No history of polyuria or polydipsia, no history of any suck rest, suck cycle, breathing difficulty, or recurrent respiratory tract infection, discoloration of skin. No history of any earliest discoloration of eyes, skin, vomiting, blood tinged vomiting, or abdominal distension. No history of any skin rash, ulcers in oral cavity, ear discharge, or prolonged fever. No history of passing worms in stool, pica, perianal skin rash. No history of any abnormal movements of limbs, altered sensorium, or loss of consciousness.
Anyway, I think, again, can you stop sharing? Yes, Priyanka, because I think this part is also important. Yes. I think who will participate in the discussion? Dr. Shivani, please make your video on, if you don't mind. Good. Let us try to understand whatever the negative history Dr. Priyanka has. Are you from the same institution or some other place? Dr. Shivani? Unmute yourself. You are muted. Unmute yourself.
Sir, MP Shah Medical College.
Jamnagar.
Ahmedabad.
MP Shah. Sorry. Very good. She said no history of greasy bulky stool. What is your idea?
To rule out malabsorption, any malabsorption syndrome.
In which condition it can happen? Any idea?
In celiac disease.
Okay. In celiac disease, usually, do you expect this greasy bulky stool? Greasy, that means, usually oily stool. What we mean by it. Dr. Mahesh has put in the cystic fibrosis. Okay. Actually, what is my idea to asking this question, Priyanka? Always what we discuss, what is the chief complaint of the patient? Suppose if the patient of cystic fibrosis with this stool, fatty stool, chief complaint will be different. Chief complaint will not be my child is not gaining the weight or this edema. Chief complaint with the frequency of stool. Because that is the main problem for the parents. And after this, I will say problem of this, even the chronic diarrhea, malabsorption, hypoproteinemia, and then edema will develop. Or even it will take pretty long time to develop this, not, I will say, growing the child well. So chief complaint is not going to be this, I will say, the cystic fibrosis, edema, or the not gaining the weight. Chief complaint will be the frequency of stool. So this is not expected. That's why I'm telling you in the negative history, don't make the list which is given the standard textbooks. Find out that which one is relevant to your case, relevant to our problem. Right. So that's the thing. Another problem, what she has described, no history of regurgitation of fields. What is your idea, Dr. Mahesh? Dr. Mahesh, I think you can keep your video on. You are putting, I will share comments very nicely over here. Somebody has put GRD. In GRD also, what was the chief complaint? Not getting very chief complaint with the vomiting or respiration problems. In GRD, child will not be presenting not gaining the weight and edema. So my point is that negative history which you are selecting, that which is expected in that patient, and still it is there or not. That will help me for my further process. That one particular point about presence or absence, presence will strengthen my possibility. That yes, this can happen, and it is there or not. So accordingly, I will select the case. Rash and joint pain, Priyanka, what was the idea?
In any case of arthritis, septic arthritis or something like that, so related to that, the edema would have developed.
Priyanka, patient of septic arthritis will present in a different way.
Yes, sir.
What will the main complaint? Fever. And suppose
yes.
the pain, child is what mother will complain? Not moving the limb. Sometimes it's a pseudo paralysis.
Yeah.
That will be the complaint. Right. This edema, I will say edema feet, yes, in a case of even the fracture or even the arthritis or any the swelling can develop, but that complaint, chief complaint will be different. It will not be just complaint of the edema. On the contrary, chief complaint, fever, child is irritable, constantly crying, not moving the limb, not allowing me to touch. These will be the complaints, right? That's why I'm interested to bring to all the students to your notice that always take the relevant point. Crying while passing the urine, red color urine. I'm not expecting the renal cause for this, I will say 11 months old child. What renal problem? I will say post-glomerulonephritis. This is not the age. Even suppose UTI, then chief problem with the fever, burning micturition, crying micturition, then maybe the red color urine. But not the only red color urine and in this way. Polyuria polydipsia, yes. That's good point.
Good point.
Renal tubular acidosis can present with this polyuria polydipsia. Sometimes even not so common, rare, but even diabetes insipidus, diabetes mellitus, yes, they can present. They can present in this way, agreed. And that's why I think, and another thing, if somebody is asking, you should have this explanation in your mind. Suppose if you don't have the explanation, better not to mention Shivani. Unnecessary, don't invite the trouble. If we put something that we are not able to explain, then it creates a problem for us. Circulation cycle, breathing difficulty, again, in a case of suppose VSD or any congenital heart disease present with the cardiac failure, chief complaint will be difficulty in breathing, difficulty taking feeds, then breathing, right? So, and then circulation cycle, if you ask, mother does not know what is the circulation cycle. That's we'll have to define. Yellowish discoloration of eyes, skin, vomiting, blood tinge vomiting. Priyanka, what was your idea for this point?
Sir, in any case of liver dysfunction.
Which liver dysfunction may present in this way?
Sir, in neonatal cholestasis, like proceeding like PA5C or something.
What is the presentation of neonatal cholestasis?
Sir, there will be jaundice.
Priyanka, cholestasis itself. So what will be the complaint? Jaundice.
Sir, jaundice and pale colors too.
Right, that okay. Jaundice then later on can go for, I will say, cirrhosis or something and come present with the edema is a different story. But the chief complaint, I think what I mean to say in this patient, I'm not expecting that this is going to be the cholestasis in any way. And then why we should put it? Skin rash, ulcers in cavity, ear discharge, prolonged fever. What was the idea?
Sir, in any case of unvaccinated child, measles.
Okay. Passing worms, yes, I think that's important. Pica, okay. Abnormal movements of limbs, altered sensorium, loss of consciousness. What you wanted to heat?
In any case of dyselectrolytemia or something like that.
Anyway, what is my point over here? Please, not only for Priyanka, but all the students. You know, you will invite trouble in the exam by putting this type of the negative points. Negative points should be selected related to your case. There can be 1,000 causes, I will say, for one particular reason in the textbook, which is not expected in that particular case. That's why, please remember one thing, which is very important statement, which I want to guide you. I will select the negative points. That presence or absence of that particular point which helped me for further my thought process. Whether should I consider that condition or it is not possible. Or second, absence or presence that point will help you for differential diagnosis. And third, some complication is expected in that case. And whether this patient has complicated, suppose a case of some liver problem. And then the bleeding problems, hypoproteinemia, bleeding tendency is common. Therefore, here I will ask, is there any point of even the black colored stool? May not be even him, black colored stool I will ask, because that is relevant point. Because that indicates the coagulopathy. May not be even the obvious bleeding or maybe the occult bleeding. So the point is selected the negative points in such a way that presence or absence helps you in your thought process. Very good. But you have taken, I will say, good points so that we could discuss and we can learn. So anything, Dr. Jaisi, from your side to add before we go further? Please.
Yes, sir. The negative history should be very meticulously selected to the points which are very relevant to our presenting complaint. That should be our motto, that unnecessary, the irrelevant complaints or irrelevant findings, they should not be included in the negative history. That will be a positive, beneficial act towards us. Thank you.
Fine. Priyanka, now again you can share the PPT and take the history further.
In the past history, there is no history of any similar complaints in the past, no history of previous admission for the similar complaints, no any history of recurrent episodes of loose stools, vomiting, or any other significant illness or transfusion history.
Okay. Again, I think the past history also will take the very meticulously. Which condition will be similar complaint? When we are expecting the repeated or episodic problem, suppose bronchial asthma, if you are thinking, you should ask always this, whether is there any history. Suppose in a case of seizures, history of seizures in the past, so that you can decide whether is there a possibility of some recurrent cause for the seizure. But I think this type of the edema or this not gaining weight, not gaining, I will say, weight, is not going to be the similar complaint in the past. It is going to be the present complaint, right? Previous admission, yes. History of hospitalization, you should ask. Whether any due to any reason, that's very important. Fine, good. Please go ahead. Take it further.
Then antenatal history. Right. Mother's conception age was 31 years. This is a 5th order male child. She was not a book case. No history of fever with rash or painful swelling behind the ears, exposure to pates during pregnancy. No history of documentation of any high BP or sugar readings or any thyroid disorder. No history of bleeding or leaking PV, foul smelling discharge, burning micturition during pregnancy. No history of radiation exposure during pregnancy, alcohol or tobacco substance intake. Antenatal anomaly scans were not done, but quickening was felt at 5 months of pregnancy by the mother. Have not taken an injection, Tdap, or iron folic acid or calcium supplements.
What injection is available in the pregnant woman in the government hospital?
Sir, we have Tdap injection as soon as the...
Whether it is available in the government hospital, Tdap?
Yes, sir, it is available.
All the pregnant hospital supply, government supply?
Yes, sir.
Priyanka, you can verify whether Tdap is government supply. Suppose some hospital is providing, maybe I will say provision made by that hospital, but government supply is not the Tdap. T small d. If somebody is, I will say, interested or known, or if you are offering, it's a different. Ideally, it should be Tdap. I agree with you. But in the government hospitals, supply is not the Tdap. It's T small d. Right? Because here the same questions people are going to ask you: folic acid, calcium supplement. You know what is the government supply for the folic acid and iron?
Yes, sir. Folic acid, it comes in 5 mg preparation, and iron tablets come under Anemia Mukt Bharat, 60 mg tablets.
Whether they are in the same or different tablets?
Different tablets, sir.
And then what is the concentration the lactate in these pregnant women? And what is the supply for this, I will say, in the pediatric practice, pediatric OPD? And what is the strength of the iron and what is the strength of the folic acid, which is supplied by the government of India?
Sir, we get the supply of iron folic serum, iron syrup in the form of 20 mg per 1 ml, and we prescribe at a dose of 3 mg per kg per day in the pediatric age group.
I am talking of this nutritional supply by the government of India. Which type of the tablets are available? Suppose Anganwadi worker. In this Anganwadi, what supply is there? For the pregnant women and for this, I will say, children. Folic acid and iron. Even sometimes somebody may ask that how will you identify from the color of the tablet?
Yes, sir. Red color tablets come for pregnant females, and pink color formulations are also available. And Anemia Mukt Bharat, they have introduced.
Please, what is my idea? Write down this question, verify it, and examiner asks what is supplied in I will say, a hospital. Because by and large, most of the government hospitals where most of the patients are attending, then what services we are able to provide or providing, that they are going to ask. That what type of the tetanus, what type of this particular, I will say, Dr. Sakshi Tyagi has put it, red for the pregnancy and pink for the children, probably yes. Concentration of even the iron is 100 milligram probably in the pregnant and 60 milligram in children, right? And probably 5 microgram, 1 microgram. I am not sure, that's why I don't say, but please verify, right? This is very important that we should be aware of it. And particularly, when the case of malnutrition, probably they are going to ask these questions. Okay, take it further. Birth history.
Born at 38 weeks by a normal vaginal delivery with a birth weight of 3 kg. Baby cried immediately after birth. Shifted to mother side. Initiated breastfeeding within 1 hour. No prelactal feeds were given. No feeding difficulties were observed. Uneventful natal and postnatal history. Exclusive breastfeeding started and it was continued. No any history of NICU admission. Then
Good.
immunization
so I think from this history we come to know that was full-term birth weight was 3 kg. BF was starting. So in this baby, we are not expecting any problem. Okay. Further?
Immunization history. Immunized as per NIH schedule at the nearby community health center. Last vaccination was done at the age of 9 months of age. BCG scar was present and observed on the left arm.
Okay. Again, just from the exam point of view, I want to draw attention. Here somebody will ask that what is the national immunization program? And suppose for the 11 months old child, what we are expecting? Anybody can say? Let me go to, I think, Dr. Mahesh, you are answering. Dr. Mahesh, suppose 11 months old child, which vaccines you are expecting that the child had received as per the national immunization program? Suppose up to 11 months they have completed.
Hello?
Yes. Very good.
Hello? Am I audible?
Yes, sir. Dr. Mahesh, can you introduce yourself, please, for your knowledge point of view?
Sir, I am Mehul Gosai. I work at District Hospital in Buldana, Maharashtra. I am a consultant there.
Oh, you are pediatrician?
Yes, sir. Yes, sir.
So I think it's a good that even practicing pediatrician is also participating in this teaching session.
I listen to your video, sir.
Oh, very nice of you.
Yes,
I
sir.
think
Yes, sir.
then you are in the government sector, so you are the, I will say, appropriate person to provide this information. I think
Yes,
I
sir.
think other students should listen to him. Dr. Mahesh, can you just provide the information that what
At
vaccines or 11 months in our government scheme child must have received?
yes, sir. Yes, sir. At birth, we give zero polio dose, OPV, hepatitis B, and BCG.
Right.
At 6 weeks, we give Pentavac, OPV first dose, rotavirus first dose, pneumococcal first dose, fractional IPV first dose.
Very good. I think you are fully aware. Absolutely.
Yes, sir.
And then
At 10 weeks, yes, sir. At
yes,
10 weeks, at Penta second dose, OPV
Yes.
second dose, Rota
Right.
second dose,
Right.
no, PCV not will, PCV
Yes.
at 14 weeks. 14 weeks, IPV and PCV, rest of the same.
Yes. So I think that will be there. And again, 6 months.
6 months we don't have influenza.
We don't have the schedule. Government schedule we don't have. Then directly,
No, sir. No, sir.
Directly
Direct
9 months. 9 months.
Yes, 9 months we have measles, MR, measles,
Yes.
rubella.
Please remember here we in the government sector we are providing MR, not the MMR. Yes.
Yes, sir. Fractional IPV third dose.
Yes.
Hello.
Yes,
PCV PCV booster dose.
Right.
And vitamin A dose.
Exactly. That is the thing. I thought that you are able to recollect. That's good.
No, sir.
You know, vitamin A prophylaxis program will start from the measles 9 months of age.
Yes, sir. Yes, sir.
And up to the even 5 years, we provide 9 total doses.
Total dose. Yes, sir. Yes, sir. Yes, sir.
People have suggested some modifications. That's a different story. But at present, that's the thing which we are following. So again, the message to all the students. Thank you very much, Dr. Mahesh. I would say,
yes, sir, yes,
I will say you are practicing pediatrician, attending our teaching sessions, and even answering.
Welcome, sir.
Like the student, it's really quite appreciable. Very nice of
yes, sir, yes, sir. Thank you, sir. Thank you.
So I think that's the thing for the students that, all these questions are going to be there. We should be prepared. Priyanka, okay, you can take the history further. Good.
So now we go to the developmental history.
Right.
Gross motor, child has attended a whole day and rollover at 6 months, seats with support 6 to 7 months. Then fine motor, bidextrous reach, he has attained till at 6 months and unidextrous reach also after that. Then language, who's at the age of 2 months, then laughs out loud at the age of 4 months. He has not achieved monosyllables or bisyllables. Then social, he has attained a social smile at the age of 4 months and recognizes mother. Stranger anxiety has developed at the age of 6 months. And
anyway, I think one point which I would like, yes, okay, here you can take it further. Let us complete, then we'll be back.
So developmental question comes around 52.5. Hearing and vision are not.
Okay.
Then we come
Dr.
to
JC, you can focus for the dietary history. I wish that you would be discussing very nicely, please.
Yeah.
Patient was exclusive.
Yes, sir. Priyanka, complete it. Sorry, please.
Yeah. So patient was on exclusive breastfeeding till 6 months, 7 to 8 times per day and 3 to 4 times at night. No history of any bottle feedings or formula milk. Complementary feeding started at the age of 7 months and breastfeeding was continued along with. And she has been breastfeeding the kid 5 times a day and 1 to 2 times at night. Diet by 24-hour recall method during pre-illness period. Only 3 out of 7 food groups were included in the diet. Morning, 2 biscuits, and afternoon, 1/4 katori khichdi, and at night, 1/4 katori khichdi. And the required per day diet kilocalorie was 544, and taken was 500, and protein was 11, and protein requirement was just 4. And the deficit comes around 118 kilocalorie per day and 7 grams per day.
Right. Yes, sir. Take it further.
Families
Yeah, Priyanka.
stop sharing. Yes, sir.
Yeah, Priyanka, you have very well taken the dietary history. But to start with, we should start with the early initiation of breastfeeding, whether the breastfeeding was started, early initiation of breastfeeding was done or not, whether the colostrum was fed to the baby, for how many days the colostrum was fed or not, or then the exclusive breastfeeding, you have told that it was continued till 6 months. Was it continued for 6 months only, or it was for 6 months and then continued till 11 months till present? It was still it is continued. And what was introduced at 6 months as a at 7 months as a complementary feeding? So you have to mention all these things, that the complementary feed was started with these things, and in this much of the amount, at least this much of the feeds, this much of the snacks, this was the frequency, this was the texture, this was the type of complementary feed which the baby was receiving. So you have to elaborate the complementary feed in detail, because we are dealing with the patient of malnutrition. That's still we don't know, but ultimately it's a case of malnutrition. So we will have to elaborate complementary feeding in detail, that what is the texture, what is the frequency of feeds, what is the amount of feed the child is getting, what is the this responsive feeding or active feeding, or whether it was hygienic or not. All these things we have to elaborate in dietary history, and so that we have a concrete dietary history. Because the child is not gaining weight means we have to consider the diet and the complementary feeds in quite focus now. So we have to take it in detail. Yeah, sir. So we have missed something in the dietary history. And regarding breastfeeding also, how many times the child took the breastfeeding, what was the frequency, whether the foremilk or hind milk, which type of milk the baby was receiving. These things we have to include in dietary history. Yeah, anything more, sir?
Yes, yes. I think, somebody is going to ask it, Priyanka, that what you are expecting the amount of milk, breast milk, at the age of when the child is 6 months old. Supposing the calories, if you are when calculating, how roughly will calculate that what amount is going to be secreted by the mother when the child is 6 months old, or even the later on 9 to 10 months old, later on at 1 year old. What lactation a normal mother we are expecting? Any
Sir,
idea?
breast milk formula is being calculated like post 6 months. From 6 months to 8 months, that is 200 kilocalorie per day. And
No,
from breast milk.
Priyanka, my question is what amount of the milk?
Okay.
That means how much, suppose the mother is healthy, we know that initially amount will be more, gradually it will be decreasing in the amount. So roughly at
40
the
to
6,
60
7
ml
months.
per feed. Yes, 40 to 60 ml per feed.
It is not going to be per feed, it is going to be the total amount per day. Right. Anyway, but these are the questions for your exam which you should keep in mind. What is, I will say, the initial stage when the mother is having the mature milk started? What we are expecting total amount of the milk secreted by the healthy mother? These questions are going to be there. Therefore, I think all the students, please keep in mind. Then the same time, you will have to go for calculation of the calories. So at 5 months, roughly how much, suppose she is giving regularly. She is secreting good amount. Mother is healthy. And therefore, no other factors are playing the role. Then what amount you are expecting? You know that initially it may be just 700 to 800 ml per day. Later on, at 6 months, around the 500. Which maybe they when some mother maybe the 450 or 500, somebody mother will be having the 550. But what I mean to say that 400 to 600 amount will be there. and gradually even around 1 year, roughly around less than 400 ml per day. So that you can calculate for this calculation. Suppose 100 ml for the breast milk, what calories you consider?
67 kilocalories
Very
and
good.
0.9 to 1
So
gram of
another
protein.
point I will say, we'll not be able to discuss all the points, but I will guide the students in this type of the malnutrition or nutritional case. Examiner is going to ask all the details of nutrition, and particularly the breast milk. The reason we know that pediatrician should be fully aware of all the breast milk problems, or I will say management, regarding the lactation, regarding the issues, even the how in the newborn you will decide that the mother is secreting sufficient milk. So all the points, what is the fore milk, hind milk, mature milk, because all the points are having relevancy or it's important, right? Anyway, it's difficult to complete the whole discussion, but I think just to give the idea. Anyway, Priyanka, now we can take it further. Anything remains in the history, or you can take for examination, because I will have to look at the time also.
Okay. So family history, fifth order born male child, born out of non-consanguineous marriage, nuclear family, 7 members were there, including parents and the children. There is no history of any TB or chronic cough in the family. History of lung cancer in the paternal grandfather. To lower socioeconomic class as per modified Kuppuswamy classification, and Pakka house, 1 room rented, all 1 and 2 windows, and no any open air defecation. Child was given water without boiling.
I will say for this uneducated, I will give the appropriate word. Better to mention in this way that not attended the school or schooling was not done. That means not gone to the school at any time, like that. But but still he can have some education even by his own also. Many people we know that even maybe the education is less or even not gone, but still they are able to manage even the very big businesses. So that's a different story, right? Okay. So the social status you can define accordingly. Okay. Now what is your summary?
Sir, 11-old male child, birth order 5, born out of non-consanguineous marriage, born by full-term normal vaginal delivery, belonging to lower socioeconomic status as per modified Kuppuswamy classification 2026, with uneventful antenatal, natal, and postnatal history, with delayed developmental milestone, was brought with the history of not gaining weight since 6 months and bilateral swelling of feet since 15 days, with dietary deficit of 118 kilocalorie per day, and 7 grams of protein deficiency. Probable diagnosis is acute malnutrition with global developmental decay.
Okay, can you stop sharing for a while? Because very important point you have mentioned, better to discuss it. The question is to others. Priyanka, who is from your institution? Any name is seen on the screen?
Yes, sir.
Okay, I think Kunal, what am I pronouncing rightly?
Nikunj.
Nikunj, sorry. Okay, so Nikunj, what is your explanation for global delay development in this patient? Direct question if I ask you, because your colleague has considered that besides this acute malnutrition, there is the delayed development. So what is your explanation? From the history. Okay, on examination, we may get some other reason.
Sir, still we cannot consider it is a global developmental delay because child may not be sensitized to some developmental milestone or.
So you don't agree with your colleague Priyanka, right? There is no question of global delay development. Is it your statement or?
Yes.
Okay. So Priyanka, he considers that there is no question of global delay development. Okay. Anybody else? What is your, I will say, idea of other friends? Other students, anybody? Dr. Shivani, what is your idea? Come on.
Micronutrient deficiency can lead to a developmental delay, like
Okay.
B12 deficiency and iron deficiency.
Okay, so she considers and she agrees with Priyanka that yes, there is a delayed development, and her explanation that deficiency of all these trace elements and nutrients and vitamins and everything. Okay. And what was the Dr. Mahendra Kumar Gupta is putting on this pre-infantile tremor syndrome can lead to the developed delayed. Okay. And I think somebody had some other, let me see on the chat box if it is seen. I think there was some other explanation also. Yes. Motor milestone will be affected more than the dominance, pre-infantile tremor, more than 2, like fine motor and gross motor milestone, speech delay. Okay. So that is the explanation. What are the chances of brain involvement in malnutrition? How much it is common seen in the practice? Fortunately now, malnutrition itself has come down, but still it is there. And therefore, how Dr. Sakshi is putting something at, Dr. Indu Saxena says it is spared. So, Priyanka, house is divided. Many friends don't agree with you. Some people are there to support you. But your colleague, I would say, sitting with you is not agreeing with you. He does not agree with you. So what is your explanation? Yes.
So nutritional deficiency, most commonly micronutrient deficiency, can lead to this sort of developmental delay. And in the first 2 years of life, that will lead to delayed neuronal maturation and myelination process. So that will also lead to developmental delay, sir.
Which book you are reading from the nutrition point of view? Elizabeth, McLaren, or some other? Which one you are reading?
Elizabeth, sir.
Elizabeth. What Madam has mentioned in this, I will say, particularly neurological affection in a case of malnutrition. What you said is right, that the myelination can be affected, neuronal can be affected, but particularly from the development point of view. Or I will say various pathophysiology, what they explain, the effect on the heart, effect on the nutrition, effect on the liver, right? Protein synthesis, all the things like that. What she had mentioned on the neurology, whether the global delayed development is going to develop. It is why I raised the question. Again, this is inviting the trouble in the exam. The malnutrition, even severe acute malnutrition, I'm not talking of mild to moderate even. In severe acute malnutrition, one thing, please remember that nature is very kind to us. And nature has taken care not to make us the handicap. Therefore, even if you see in the pregnancy also, at the cost of mother's nutrition, fetus is hardly affected. Fetus is going to get the nutrition. Even mother may go for the anemia or more degree of malnutrition, but baby is going to be healthy as far as possible, because nature is taking care. Similarly, in a case of the malnutrition, usually neurology is spared, if at all affected in severe degree at the last and minimal. It will not be going for the global delayed development. And really, in a case of malnutrition, if you have the clear-cut global delayed development, think the other cause for the global delayed development. Maybe some syndromic condition. So Down syndrome, yes, it can be. Or some syndromic condition or some other metabolic cause or something. But at the sole cause of malnutrition, neurological so much involvement, delayed development, regression is different thing, infantile tremor syndrome. But then the manifestations of infantile tremor syndrome will be there. It will not be only the neurological involvement. On the contrary, there will be the anemia, there will be the hyperpigmented knuckles. There will be other manifestations of B12 deficiency. Tremors will be there. And there will be some regression of milestone. That again, the treatment, they do recover. So, delayed, if at all, on the contrary, motor milestones can be affected to some extent. With the correction of the nutrition, they regain. But usually speech and even the personal social, they are not affected. And therefore, many a times, motor milestone is affected in this illness or malnutrition. Personal social or language is not affected. In other way, motor milestone motor milestones are normal, gross and fine, but speech is affected, personal social is affected. Then what can be the cause? In other way, if I ask you, did you follow my question? That another 2 to 3 years old child presents to me, nutritionally good, motor milestone fine, motor fine, but mother complains that not speaking much, not even attending, not playing with other children, not even address when I'm calling by the name, not looking at me. Just somebody has put Dr. Indu.
Avoid of eye contact and autism spectrum.
So autism spectrum is common on the contrary. So, if affected, which part is affected, that will guide you. That what is the likely problem. And global, that means something is there with this brain, gray matter. That can be the different reason, some syndromic conditions or insult or even the infections or so many other reasons can be there. So that's the thing that we'd have to find it out. I think here, better to go in the details of this developmental history, probably it may clarify. It may happen so, or really if we did a development, maybe some other cause that we can try to find out. Anyway, now let us go for the examination.
General physical examination, child is conscious, recognizing mother, not interested in surroundings. Vitals, temperature normal, taken by digital temperature on right axilla. Heart rate 118 beats per minute, and pulse rate is 1110 beats per minute. Regular in volume, no radial or radiofemoral delay. All peripheral pulses well felt. Respiratory rate is 28 per minute, and abdominothoracic type breathing. BP is 90/60, coming under 50 to 90th percentile in right upper limb in supine position. SpO2 98% on room air. CRT is 2 seconds. Skin pinch is normal. Pallor is present. Bilateral edema with pitting type edema present in feet. Grade 1. And no icterus, lymphadenopathy, and rubbing present.
Yes, good. Take it further. I think you can complete examination, then we'll go for the discussion. Not moving, Priyanka?
Anthropometric. Weight is 6.8 kg, less than third percentile. Underweight. Length is 69 centimeter, less than third percentile. Short stature. And their weight for length is between 25 to 25th to 50th percentile. Then HC is 41 centimeter, less than third percentile, microcephaly. And then mid arm circumference is 14 centimeter. Upper segment, lower segment ratio is 1.46. Weight for age is 72.3% with bilateral symmetrical edema in the feet, posture suggestive of kwashiorkor. Grade 1 IAP classification. Acute and chronic malnutrition as per WHO classification, fulfilling the criteria of severe acute malnutrition with stunting and microcephaly. The growth charts. And the first one is 0 to 5 years WHO boys growth chart. And HC is also less than third percentile, 41 centimeter at the age of.
I think, can you go to the growth chart, previous one? This left hand side, I will say 2B. Upper one is for the head size, am I right? Upper one, that is for the head size. Head size, what does it indicate?
Then head, and then upper one is length.
Okay, upper one is length.
Yes.
Another thing, please remember in the exam also, make it the dot only, don't make the circle. When you are plotting on the growth chart, you can make the dot. Don't make the circle around again the dot. That is very, I will say, standard method of plotting on the growth chart. Okay, what is the next?
It should be a dark dot, no?
Yeah, dark dot, but not the circle.
Yeah, not circle.
Weight for age, and the length for age also lies below less than third percentile.
Okay. I think 11 months old child, 69 centimeter, not bad. 70 centimeter we are expecting at 10 months old. Anyway. Okay, take it further.
Head to toe examination, and decreased in circumference, no frontal crossing, anterior frontal open at the level of 1:1 centimeter, 1:1 centimeter, and posterior frontal is closed. Hair, lusterless hair, sparse hair, thin, easily pluckable, brown in color, no areas of alopecia. Face, no dysmorphic features. Eyes, paler present, no icterus, no shrunken eyes, no tear dry film, or no conjunctival cirrhosis present. Ears, no low-side tears or no discharge. Oral cavity, lips and tongues are normal, and no cheilitis or stomatitis, glossitis, oral ulcers, gum bleeds. Neck, no lymphadenopathy. Chest, normal, no evidence of nutritional deficiency. Abdomen, normal. Extremities, bilateral pedal edema, pitting type of edema, present and limited till dorsum of the feet, limited till ankle. Grade 1, shiny skin over the edematous lesion, no any knuckle hyperpigmentation present. Nails, paler present. Spine and back normal. Genitalia normal, no any perianal excoriation. Skin, shiny skin, dermatosis changes, flecky pen type dermatosis, alternate hypo and hyperpigmentation noted. Skeletal system, no any bony deformities. Then systemic examination. For abdomen, shape of the abdomen normal. All quadrants move equally with respiration. Umbilicus central, no superficial dilated veins, no scars. On palpitation, soft, liver palpable 3 centimeter below right costochondral margin. Soft in consistency, sharp borders, smooth surface, non-tender, liver span 5.5 centimeter, no splenomegaly, bowel sounds heard well. Respiratory system, bilateral equal air entry present, normal bronchovascular breathing type of breathing, no added sounds present. CVS S1 is heard normally, no more. Nervous system, child is conscious, modified GCS 15/15, no cranial nerve deficits. Motor system, no evidence of hypotonia. Muscle mass normal, and power 5/5 in all 4 limbs. Tone normal. Reflex, deep tendon reflex plus 2/4. And sensory system normal. Cerebellar system normal. Spine, back, and skull normal.
Okay. You have any photographs of the patient, Priyanka? Have you taken?
Sir.
Okay, if you don't have it, it's all right. Otherwise, if you have taken the photograph, probably you can show some of the pictures like dermatosis and other things, edema. Anyway, can you stop sharing? Yes, good. You know that online discussion and offline discussion makes difference. Suppose with the physical presence, if you are discussing, it is very common that examiners will ask you to demonstrate some signs. And it is going to be common. So I think every student say, please, you should do it routine, at least in your ward, so that it does not create any problem in the exam, because it is going to be there. With that, I think before we go further, mid upper arm circumference, you said 40 centimeters, 1/4.
Yes.
How will you explain?
Sir,
What do you expect? Do you expect this mid upper arm circumference 14 centimeter?
sir, but ideally, in case of kwashiorkor, sometimes because of the subcutaneous edema, we can get a false sign.
I think you have mentioned in your findings that edema is grade 1. And by grade 1, it does not, I will say, extend beyond this ankle.
Yeah.
So either in your statement, you will have to change. Whether edema is really grade 1, Priyanka?
Sir, it was 2 mm in depression and on the 10 seconds of pressure. It was just around 2 mm of depression, and the skin reverted back after that.
Priyanka, I think you know how we go for the grading of edema in a case of kwashiorkor. Is there anybody? I think let me go to other students also, so that they can also remain active.
Yeah.
Dr. Indu, I think she was putting some comments. So Dr. Indu, are you there? Or even your colleague Priyanka? I think it's a Kunal name. Oh, sorry, I forgot again. Nikunj, yes. Nikunj. What are the gradings of edema in a case of kwashiorkor? Somebody is going to ask this question. Very simple.
Sir, grade 1 is pedal edema.
It is number 1. It is going to be only pedal edema. It is not right. Pedal edema. Yes, it is pitting bilateral pedal edema.
Then facial puffiness.
Okay.
Then edema over face and back. And grade 4 is ascites and generalized edema.
Okay. So now, Priyanka, in your case, edema was up to what level?
So edema was only in the bilateral pedal edema, sir.
So what is edema? Grading 1. Grade 1. If you say grade 1, how will you explain the mid upper arm circumference? 14 centimeters. So, something somewhere is wrong. That one should be very important. Second, liver you should sharp. What is the normal border of the liver? Normal level, I will say, suppose liver is normal. What will be its border? Anybody? Yes, Dr. Indu is putting rounded. And suppose sharp, in which condition it will be sharp? In which condition it is going to be sharp, Dr. Indu? Not the storage, but cirrhosis of liver. So once you put the, I will say, sharp border, therefore again, as I said, when you are describing, we'll have to be very cautious. That here, if you say that it is the enlarged liver, soft, non-tender, smooth surface, rounded border. If you say sharp, then it indicates cirrhosis of liver. That's why you should be very, I will say, careful when you are putting it. Another thing, once you say child is conscious, there is no need to mention the Glasgow Coma Scale. Glasgow Coma Scale is meant for assessment of the level of consciousness in the child presenting with impairment of consciousness. Once it is conscious, it is understood that Glasgow Coma Scale is 15. Right. So again, there is no need to repeat it because it becomes very clear. I think here you should go for even the grading of pallor because it is a case of malnutrition. You have any idea? Suppose simply how we are explaining the Anganwadi workers for assessment of Palmer payload. How do you explain them? How do you grade them?
Sir, pale sclera will be grade 1, conjunctiva. Then paleness over the palms will be grade 2, and then paleness over the both mucous membrane and palm, and that will be grade 3.
In which book it is mentioned, Priyanka? Please remember, from the clinical examination point of view, these are the common sites where you will check it. But grading is given from the Palmer payload. And their gradings, how they are given, that suppose palm is pink, no anemia. Palm is pale, but creases are pink. Right? It's mild to moderate anemia. When palm is pale, creases are also pale. It's a severe anemia. This is very simple clinical, I will say, device which we can explain to even the paramedic people so that they can refer in time. Suppose if they say that creases are also pale, that is severe anemia, they will refer to the nearby hospital. So that child can be managed before goes for cardiac failure or some problems and complications of anemia. Right, that's the thing. Another way is from the estimation of hemoglobin. Another way of defining the anemia is estimation of hemoglobin. That hemoglobin expected for that age and sex, male and female, will be different. Up to 10, it is mild. 10 to 7, it is moderate. 7 to 5, it is severe. Less than 5, it is very severe. Again, this is the WHO classification of gradings of anemia from the hemoglobin estimation. That was from the clinical. And these questions are going to be the very common, which probably all of us should be ready to explain particularly. And you know, this short case of malnutrition is very common in the MD and even DNB exam, both the exams. Okay. I think lot many things are there. We may not be able to complete, and already we have reached to the end of time. So already we have overshooted, but we may not overshoot too much. We have to keep in mind the time. But in a case of malnutrition, use of the...
regarding...
Dr. Dehury, please.
Yeah. Sir, regarding grading of dermatosis, they should also know the grading of
dermatosis. Yeah, in case of
he has mentioned that there is dermatosis. That means he have mentioned specifically the flaky pant dermatosis. So the examiner may ask that what are the grades of dermatosis?
Yeah. Huh? That's why he asked her with the pictures, but she has not. Otherwise, pictures will help us.
Shown that.
But can anybody knows from the dermatosis what sir has raised? Right? Good question.
Grade 1 is rough patches, then grade 2 is diffuse, and grade 3.
Not diffuse, multiple patches, no?
Yes.
Multiple patches of dermatosis. Okay. And grade 3 is flaky pant dermatosis or weeping lesions and like that. And they are grade 3. So we must know all the 3 grades of dermatosis. Yeah.
Similarly, these practical questions what sir has raised, you are going to face in the exam. Suppose somebody will ask Priyanka that have you demonstrate for edema? Demonstration of edema, presence of edema.
Yeah, very practical questions.
You can describe, yes.
Yeah.
At least you can describe that in this.
In an 11-month-old child, that specifically your child.
Yeah.
How you will examine for edema in that child?
Sir, we can examine at the leg near the ankle, near the medial malleolus region. We can put pressure for 10 seconds, and after lifting, if there is depression, that will lead to pitting type. If there is depression, that can be significant. That is the evidence for non-pitting type of edema. And over that, if the depression is between 2 mm, then that is grade 1. Grade 1. If the depression is 2 to 4 mm, then that is grade 2. And if it is 4 to 6, then that is grade 3. And if it is 8 mm of depression and lasting for 20 seconds, that is grade 4 beating type.
Priyanka, I think you can refer the book today before you go to sleep.
Yeah.
For the clinical examination of edema. I think that should be the habit of all the students. That's why I'm asking. Even till I have there, suppose something I have spoken is not, I'm not sure. I will verify before this. I will say next morning.
Yes, sir. I have.
So that we
I
can
had
remember.
read it.
No, I will say you have written. Then also please verify. Edema in the I will say for examination. Location, 2 things, anatomical landmarks. Please remember, one you said is right, malleolus. Second, best one is the shin of the tibia. And
Yes.
you press for the 30 seconds, not the 10 seconds. You said 10 seconds. That's why I said verify. It is to be pressed for 30 seconds. Count for the 30 seconds. Then you will realize how much it is long time. 30 seconds is not that easy. It's very long time, 30 seconds. And then see for the pitting that how much it is pitting is there. Right? That is the point. You know, all these times you'll have to remember. For suppose if you are looking for the CRT, for how much time you will press over the shin of, I will say over the chest, sternum?
3 seconds.
How much?
3 seconds.
3 seconds. 3 seconds, more than 3 seconds, less than 3 seconds the time. But for pressing, how much time?
5 seconds.
It's
5
5
seconds.
5 seconds.
1,001, yes.
So you know, all these things will have to be very, very careful. That when even suppose somebody asks easily pluckable hairs, how will you demonstrate? Somebody is going to ask in the exam that demonstrate me. How will you demonstrate easily pluckable hairs in a case of the Kwashiorkor?
Sir, we'll just simply put our palm over the head surface and we'll just try to see how many hairs have come out just by simply putting it.
Think I will at least appreciate your smartness. In a later tone, I'm making the comment, please.
Because we don't do generally
because you know sometimes we discuss so much that there should be some lighter moments also. Easily pluckable demonstration is not that easy. Number one, you can take the permission of the mother. Should I do? Because every mother may not like it. Even nobody will, or even any of us may not like it. So second, you know, when you are trying to pass your, I will say, spreaded hand through the hairs, particularly thumb and this finger, like this, some bunch of 15 to 20 hairs, roughly, and just to pass through it. And if you get more than 5 to 10 hairs, it is easily pluckable hairs present. That means with your spreaded hands, if you are taking, I will say with your thumb and finger, some bunch of 15 to 20 hairs, you are passing through it. And if you get more than 5 to 10 hairs, it is easily pluckable. I'm sure that hardly the textbook has given. Right? But this type of the questions for the exam, many things there in the I will say malnutrition, that for dermatosis even, which particular deficiencies are considered likely responsible? Which substances are likely responsible for this?
Zinc and vitamin A.
We will put the very common answer, but they are not the specific. You know, in the nutrition, another thing I can remind you, in general question, long question, if you put, I will say this, no, Dr. Mehul will not be able to say the examiner that it is wrong. Just you have to make it right, and then marking he can make difference. You can't say no, but it's not the correct also. But in the OSCE, they need the very specific answer. And that is the tyrosine and methionine deficiency. They are responsible for this dermatosis. Zinc can also play the role. We can't say totally wrong. That's why I said that may not be able to say the not right answer. But just, you know, how examiner we behave, make it right. But I will, from 5, I will even mark 1 or 2, not the 3 or 4. So tyrosine and methionine, yes, Mehul has put answer. So, these questions, they are very specific. Please remember vitamin A in all the way. I think the OSCE we discussed, but very important. And every pediatrician of this country should know, because it's the number one cause, preventable cause for the blindness. Hypothyroidism is the number one cause for the preventable cause for the mental retardation. And such reasons we should not miss, we cannot afford. On the contrary, nowadays, suppose if you miss the hypothyroidism, even somebody can go in the court of law and we can be punished. So not only from the academics point of view, but from the law point of view also, certain things we'll have to learn very appropriately and very, very, I will say, sharply, because in the examiner, we don't know that in what way they are going to ask. Gradings of marasmus, gradings of this. How do you know the Kwashiorkor name is derived?
From a word from Ghana. Wash.
Very good. Ghana, what is the meaning of it?
Displaced child.
Yeah. Actually, that is the red child, red baby. From that Ghana language, the meaning is there. And commonly, due to dermatosis, they have derived this meaning. Anyway, there are, please remember, severe acute malnutrition as a whole can be the full theoretical question. 10 most common causes for the mortality, 10 most common causes for even, I will say, neglecting in the severe acute malnutrition. Somebody may ask you, what is the appetite test? Anybody? What is this appetite test?
Child is kept on fast for 3 to 4 hours, and then ready to use therapeutic food is provided.
Sorry,
Priyanka,
fasting for
2 to 3 hours.
What is your idea? Why fasting you want to observe?
Because, sir, we want to see whether the child is able to accept the food after fasting, that eager to accept the food.
Priyanka, already is a child of severe acute malnutrition. My starvation will create the problem.
Yeah.
On the contrary, in any circumstances, whatever the child is taking, I will not prohibit. I will not even stop the child. So in appetite test, there is no point of observing the, I will say, fast or to keep the nail by mouth for some time. On the contrary, let me describe. Test is meant for what purpose? What is the idea of this test?
So, if the appetite patient passes the appetite test, then that means whatever nutrition we provide, we can start the nutrition advice on the home-based approach.
Absolutely.
And if the patient, yes.
Very good. Actually, the test is defies that it's a case of severe acute malnutrition without complication. Yes. Now, such a patient, should I hospitalize or can I treat at home? For that reason, appetite test is very important. If the appetite is good, this patient can be managed at home. That is the basic principle. And for that reason, according to the weight of the child, the feeding is ideally the ready-to-use food should be used, which is not available in India, and government of India has not given the permission. But routine food for the age of the child, according to the weight, they have defined 15, 20, 25, maximum 45 ml. And then when the child is comfortable, give some time and see that how much the child is consuming. According to the expectation, as I said, according to the age or weight of the baby, child is consuming, it's a pass. Interpretation is pass and fail. If it is pass, that means the child can be managed at home. If they fail, this baby should be hospitalized. Otherwise, rate of mortality problem complication is quite high. Very important for this treatment of, I will say, 10 steps also, you remember how to be managed. All the things probably we may not able to go in the details. We'll have to end over here because already we have crossed the time. But I'm sure that it was a good selection of the case. Very important I'm sure that all the students, for the exam point of view, short case is going to be there and malnutrition is even available in the general hospitals. So your selection of case was good. You prepared even very nicely. I will appreciate you and your confidence. I understand that even with this type of the presentation disturbances of the laptop and even the technical issues, any person is going to be disturbed. I understand. Sometimes I have seen the speakers, seasoned speakers, they are going to be disturbed the laptop or something, some technical issues. But very nicely, I will say, your patience was there, your colleagues were helping, and this is also part of learning. I always say it's a part of learning. Then and then we can learn. But you managed very nicely. I will appreciate you. And even your other colleagues were helping you, Hinal and all other. That's good. Even I know that for response also, your other colleagues were coming the picture. Your side person is really very nice, smart boy. He was managing whenever you are in the difficulty. So it's a good friend. And even all other students really responding, Dr. Indu, even Dr. Mahesh, we know that practicing pediatrician still attending our lecture and you are responding as the student. Dr. Bila was also there. So really, and you know, as we participate, as we interact, all of us can learn in a better way. And even Dr. Jaisingh, you know, silent listening and good comments even. He provided many important information, not only exam, but from our practice point of view also. So thank you very much, all of you. Dr. Mehul is always, I understand, I know him since many years, and whatever I will say, except he does this job to his satisfaction, and it makes difference. So I think students should take the maximum benefit of such teachers. We'll have to end over here. Again, back to organizers, Dr. Nehal Ben, Dr. I will say our president,
Thank you.
Jhankhana Ben,
Yes, sir. Yes, sir.
Dr. Lata, and even other some teachers were also, I could see on the screen. Thank you very much, all of you, to remain present even up to the 11 o'clock. It required that the interest of the people. So we'll end over here. Thank you again, and good night to all of you. Good night. Good night.
Thank you. Thank you
Over
so
to
much,
you,
sir.
Dr. Nehal.
Yeah, thank you so
Sorry,
much, sir.
we have overshooted as usually.
No, no.
No. When the learnings goes on, we don't remember what is the time. So that even happened when we were learning as a residents, and the teachers like you were taking the rounds, and we never know that when the 2 hours or 3 hours has passed. That is what the learnings are. So thank you so much, sir. It was a very nice discussion. Thank you, Priyanka. Very nicely done, even though before some glitch, but then it was taken care very nicely. Mehul Bhai for preparing the students so nicely, and the person who is behind the screen, Hinal, even though you are not seen, you are always there, that I know. Jai Singh, sir. Thank you so much for being here, accepting our acceptance. Thank you. Thank you.
Hinal was behind the conference also.
Yes, yes.
Sir, one point, sir, I would say, Nikunj was managing our accommodation, Nehal was managing scientific, Priyanka was managing the finance, and Ugrani from all the vendors. These are the team, they really work very hard for the conference also. Who is going to be appear for the exam now?
I think just it reminds me one question also for you. As I said, Hinal was invisible person for the conference. Similarly, somebody will ask, what is the invisible PM? There is one question also. That what is the invisible PM? Anybody having the idea?
Sir, invisible PM
invisible PM is commonly seen in the children of 1.5 to 2 years, when exclusive breastfeeding is prolonged. Apparently may not be having all the manifestations of malnutrition. But if you plot on the growth chart, it is falling down. I think good pediatrician, if you see that the growth chart is going down for multiple times, 2-3 occasions, it's a time to catch that the child is going for the malnutrition. So before even the malnutrition develops, you can treat and correct it. Before even all the problems of malnutrition develop to the various systems. And that is the invisible PM. Just it reminded me from the invisible Hinal from the conference that invisible PM also somebody can ask the question. So I think, always learning is interesting and enjoyable. And if we do that, I will say multiple times, as I say, from the exam point of view, let me take 1 minute. Number one, even prepare in well in advance. Not, I will say, the exam comes. If you are really prepared, if you are knowing, your confidence develops. And confidence itself is, I will say, very important for the exam. Second thing, particularly exam days point of view, particularly previous day of the exam or during the presentation, you should take the sufficient sleep. Don't even, I will say, go for the last moment prayer. It does not hardly help. Probably may disturb you. Take the good sleep. See, even take the care for your health also, because slightest your disturbances of health will disturb you a lot. So you should remain healthy, good sleep, go with the good, I will say, confidence. Even I will say good dressing, impressive, I will say, behavior, and full confidence. And while presenting, use even each and appropriate word with meaning. Without even asking the question, examiner will understand that why I have used this word, what is my idea, what I want to convey. There is no need to ask me. Examiner should be able to understand. But for that you should go with a good preparation, multiple presentations, multiple times even write down on the paper. And even with the case presentation, take the sufficient time from the history, derive some important points of the history and write down on the paper. That these points are very important, not gaining the weight, edema. These 2 points are very important for me to discuss. Accordingly, some points in the history, which is important, that I will write down. Suppose tuberculosis contact, yes or no. Vaccination, so positive points. Similarly, examination, positive points. And then I will try to draw the picture that what does it indicate, hypothesis. What system, what anatomy, what is likely pathology, what are the common possibilities. Don't go for one particular possibility which your expert has informed you, that this is the case of TB. But I will say as a whole my independent thoughts. And when you are presenting, for every point, examiner is going to ask the explanation. I should have the good explanation that why I'm stating like this. On the smart, I will say person, suppose if you don't have the explanation, don't mention. If I don't mention, examiner will not get the idea for that thing. But suppose if I mention, if I don't have the idea, then you are inviting the trouble. You are actually asking the examiner, and then you are in trouble. Suppose by chance even something you don't know, an examiner has asked you, don't take much time. You can say, sir, I don't know. And on the contrary, it's a good answer. Don't know is a good answer. That person does not know and he answering honestly no. And not necessarily every person. Even sometimes you can ask me the 5 questions. I may not be able to answer any. Not necessary that every question, all the questions we can answer. Not necessary. It does not mean that I don't know the pediatrics. That is also not there. So with that ideas, and if you prepare, I'm sure that your performance is going to be fantastic. And once, many times I will tell my students that you should prepare in such a way that examiner we should feel that candidate is knowing better than me. Then probably he's going to give the score. Because once he is convinced this candidate is well read, he knows much pediatric than what I am knowing, naturally that examiner is going to give the score. But for that, we'll have to work very hard. Anyway, I think last few minutes I talked, but I think from the student point of view, I feel that whatever we are able to give some ideas or hints to them, and some of them will take it and they do the fantastic. So exam point of view, always prepared very appropriate. Don't take it lightly. We'll have to learn from some of the, even I will say, our leaders also. Our Prime Minister Narendra Modi not taking even this small election as a lightly, in spite of his name and everything. You will have to take it seriously. It is possible that somebody else, even very small person, can defeat you. Similarly, the exam, MD examination, we cannot take it lightly. We have to go with the full preparation. Anyone you can challenge the examiner that, sir, come on, I am well prepared. And then I'm sure that you can enjoy. And even the examiner is also convinced he's going to the best score. I'm sure that he will take even some of them these tips and you can prepare it. Thank you very much and good night. I will not take much time now.
Thank you.
Thank you, sir.
Thank you all.
Again, next Thursday we'll be there with some new topic.
Yes, sir. Next Thursday we are going for a growth chart.
Right.
Panel
Good.
discussion is
Yeah.
not because this time we have 5 Thursdays. That's it.
Yeah, fantastic. I will say growth chat. Nobody should miss. At least I stake here. I will attend so that I can learn.
Thank you. Thank you so much, sir.
Good
Good
night.
night, all.
Good
Thank you
night.
all. Good night.
Good night.
Well done.
Good night.
Bye.